So why don't we take this time to get started, be respectful of people's time. I'd like to welcome everyone. I can see, yeah, there's even more people joining us as we're starting. So welcome to our research grand rounds. We carry on amongst the current situation that we're in COVID, and welcome each and every one of you. Today is a special presentation of research rounds. It'll be facilitated by myself. My name's Doug Archibald. I'm the research director for the Department of Family Medicine. And along with me are two of our investigators. First of all, Sharon Johnston, who is a practicing family physician at the Primrose Clinic and one of our esteemed investigators. And also Dr. Bill Hogg, who I don't think really needs any introduction, but he is our clinical scholar program director and researcher with the department. So very privileged to be able to present with these two esteemed investigators. Before we begin, just a little bit of housekeeping. I'm sure by now we are all very familiar with Zoom, but how I'd like to facilitate things is that Sharon will actually be controlling the slide presentation today, and I'll be facilitating the discussion. So I'm going to ask, please, if you can all mute yourselves. You do that by just placing your cursor towards the bottom of the screen and just pressing the mute sign, if you can do that. If at any time during the presentation you have a comment or a question, if you can just go to the chat screen, that's, again, if you just move your cursor down towards the bottom of the screen and enter just that you have a comment or a question. I'll be monitoring the chat screen. Wait for me to acknowledge you. And when I do, then you can unmute yourself and ask your question or make your comment. I think that's probably the best way of doing that, is now we're approaching 30 participants. So this is wonderful. Okay, so Sharon, if I could ask you to move the slide, that would be great. This is how we'll proceed today. I'd just like to give a brief introduction about our current situation, and then that will lead into a presentation by both Sharon and Bill of an example of a research endeavor spurred on by our COVID crisis right now. And then we'll have a time for questions on that given project. And then I like to open the floor to discussion and further research questions that we either are asking or we should be asking for family medicine and primary care. So next slide, please, Sharon. Okay, so just to give a bit of an introduction, I first want to recognize our given situations here, and that for many of us, either research has been put on hold, it has stopped, or maybe it shifted, and for some, perhaps even it has continued. But I do want to recognize this, that we're all in we're all in different situations, but those situations certainly have changed. A big part of this, of course, is that many of our research teams are working from home. And this certainly does bring many challenges. And I do want to recognize that. I do hope that everybody is keeping safe and keeping well at this time. This is certainly a time of uncertainty. We're not really sure what the next steps are. But in understanding that, we do see that there is being a priority to COVID-19 related research activities. First of all, in terms of funding, this certainly does bring with it some opportunities, and we'll be talking about these today. And it also means that for existing projects that maybe have been put on hold, or there's some change to the projects, that many studies, and many funders are understanding this and extending time with their current projects. So this can mean a delay in reporting, in financial reporting. It can also mean possibly that if you have been doing some travel, or you've gone to, or you've planned for planned for travel to a conference that's been canceled, that there's reimbursement for that from a number of different funders. Next slide, please, Sharon. Specifically regarding Tri-Council funding in CIHR in particular, I think many of you have known that the spring project grants have been canceled. CIHR has made it known that there's been an extension for existing grants. And as I mentioned earlier, there's a priority for COVID related competitions. Next slide, Sharon. I'd just like to share with you some of my observations over the past month. And certainly there has been a drastic change in the way that we conduct ourselves and conduct business. It's certainly not business as usual. We've seen a drastic change in healthcare delivery. One of those changes certainly has been from in-person to virtual care. For many people, it's been about reactivating knowledge, skills, and competencies as well, and other changes as well. As many of you who are in the clinical setting can certainly attest to. As well, this has meant a change in training of our medical students, healthcare education students, and our residents in family medicine. We're seeing that there's now a shift from that face-to-face learning to online learning. We're facing a situation where examinations have either been canceled or they've been deferred to a later time. And then in terms of reassignments and being able to ensure that learners have good learning opportunities. So these are many of the challenges that we face, but in spite of this all, and I think, in primary care, in particular, we've really been learning to be resilient and to be creative and to be able to adapt and to adjust to new circumstances. So I certainly want to applaud all of you who have been able to make these adjustments. So this is certainly with regard to how healthcare has been delivered, how we continue to train learners, and then how we adapt our research activities too. And with that now, I'd like to hand things over to Sharon to talk about a research initiative that has really been transformed and adjusted to react to the COVID crisis. So Sharon, I'll hand things over to you.
Thanks, Doug. Just wave if you can't hear me. So it really has been fascinating to see how quickly we've had to adapt on the clinical front, almost overnight, drastically changing the way things are done, and learning every day. And in a very similar manner, how quickly we've had to adapt on the research front. I think, like many of you, I've just been in awe at the unprecedented interest in the type of research that we do, largely looking at public health and primary care solutions, and the number of competitions and the speed with which they are coming up and asking for solutions. And really, this has forced us, much like adapting our clinical care, it's forced us to adapt our research, our projects, new projects, including developing some new collaborations. And I hope at the end we'll be able to introduce some individuals, I think, who have joined us today, who we are starting a collaboration with, which is always welcome. Today, I'm just going to tell you briefly with Bill about a project that we essentially have adapted from ongoing funded studies to propose as a way to help primary care and public health manage through the COVID-19 pandemic, really using, as the title suggests, predictive analytics to model, monitor, and respond to resurgences in COVID-19 like symptoms by neighborhoods and rates of physical contacts. I think we all know that COVID-19 has upended a lot of our social norms. As Bill was saying, many of us had a Zoom Easter with family. Ramadan starts this evening. Many people will be not having the typical family interactions. It's also dramatically changed our work patterns. I think what many of us are starting to plan for and adapt, certainly on the clinical front, is that this isn't just 2 weeks or 4 weeks. We are going to have to learn to manage, to live with the coronavirus for another 12 to 18 months, allowing our clinical care to adapt, still meet the needs of our patients, allowing our society to return to normal function, whether that's people going back to their jobs, kids going back to school. We know now that we have to plan for the future with the virus and a potential resurgences, a very real possibility. We've seen the impressive impact of the physical distancing policies in Canada and what that has done in terms of flattening the curve, decreasing the peak, and a very powerful tool, and one that is likely to be a crucial part of our management going forward for the next 12 to 18 months as we develop our testing and treatment capacity and hopefully the arrival of a vaccine. What we also know is that primary care doctors and other primary care providers are on the front line managing patients, families, and are a crucial resource in our efforts to monitor and manage COVID-19. I think there's been a lot of attention, rightfully so, on the hospitals, initially worried about what a surge would do there, now on our long-term care sector, and a lot of work needed there. But primary care is very much on the front lines of this and needs solutions as well to help us meet the needs of our patients. And so this study is looking, one of our main goals is better data for better decisions for primary care providers, for our practices, that we could also share with public health so that at the decision-making, regional decision-making, hopefully we're all making better decisions. I think all of us know here, 95% of Canadians have a family doctor or primary care provider. Typically, family physicians, primary care providers are a trusted source of information. I was reflecting before the round started. It was only 2 months ago that I found that I was spending between an hour to an hour and a half a day talking with patients about COVID-19, whether or not they should travel for March break, what they should do. Now I find I'm talking with patients and trying to tell them how, discuss with them how to adapt, whether they can go out or not. There is a ton of information out there, and yet many people are overwhelmed or not getting the information they need. And primary care really is a trusted source for many patients. We know that we need better information to drive decisions regarding physical distancing policies, and we hope that better decisions will allow our policies to be more targeted, whether it's frontline primary care providers trying to assess the risks of bringing patients into the clinic, the risks in advising patients on simple things like, should they be going out? At what point can we say it's you know, given the profile of our different patient groups, should they be going out grocery shopping or not? We know that each of these restrictions imposes significant costs, and we need better information to help us do our jobs. We know public health needs information to help guide the physical distancing policies that have been imposed largely at a provincial level, and whether we can get more fine-tuned to start talking about regional policies. We hope we can. And people who are making choices about whether or not to go to work, to open up their job, to visit with family and friends, will need information and understanding of the different risks faced by different groups in different communities. And that is where I hand it over to you, Bill.
Thanks, Sharon. Good morning, everyone. I'm going to start presenting in French and then return to English in a couple of minutes. Comment fournir des meilleures données? Depuis 4 ans, nous avons travaillé à créer un service qui permette des médecins de famille à communiquer avec leurs patients. C'est un service automatisé avec un faible fardeau et qui ne coûte pas cher. Nous croyons que ce service est utile en ces temps de pandémie. Utilisant ce service, nous pouvons recueillir les réponses des milliers de patients qui nous permettent de mieux comprendre la prévalence des symptômes respiratoires dans la population et l'impact des restrictions de la distanciation sociale dans la population, inclus les plus vulnérables. So how do we get better data about the prevalence of COVID in the population and its impact, including differential impact on vulnerable segments of the population? So our solution is CPIN, which is, I think, the next slide, Sharon. It's the Canadian Primary Care Information Network. It's an automated communication system between family physicians and their patients. Low burden in terms of its impact on the providers in the practice and the receptionists in the practice. And certainly very low cost, pennies this will cost compared to, I learned the other day that the Center for Medicare and Medicaid in the United States has increased the cost of doing the tests, the nasopharyngeal tests in the United States. They've increased the cost to make sure they're incentivizing more testing and a faster response by different laboratories in the United States. And they've increased the cost of just analyzing a test to $100 US. So I think you'll see that at least on the cost side, our proposal, if it proves to be successful, will save a fortune. So next slide, Sharon. So the CPIN is a service where we use data analytics to connect into the patient's, into the physician or office's electronic medical record. And it connects and it pulls out information that it needs to then be able to communicate, for the physician to then be able to communicate with his or her patients. So we pull out the age, the gender, the nature of the upcoming appointment, things like that. And then we can tailor the messages that we send out to patients. And in addition to sending them information, we can also then ask them to complete a short survey. And we've had done pilots of this in 3 provinces, in over 100 different practices. And we have found that because our patients see this coming from us, they are willing to respond. And we get fabulous response rates, as high as 60% response rate. So our plan is to use this data collection infrastructure to send surveys to patients, surveys by the tens of thousands to patients in our practices. So we're going to set up, in essence, COVID Sentinel practices, and then we will survey the patients in these practices on a daily basis, asking them, do you have a cough, a fever, a headache, sore throat, shortness of breath, etc. And we will get a sense of whether or not these people have what we refer to as COVID-like symptoms. Now, the influenza season is over, and colds, the typical normal colds, have totally been suppressed as well by the physical distancing procedures that are in place. So we think that a substantial percentage of the people who respond to us that they are having COVID-like symptoms may well have COVID-19. Next slide shows that we've partnered with a private company called ClinicConnects. It's a IT company situated in Canada. We sought out this company some years ago to work with us to create the ability to send messages and create the ability to survey patients. We sought them out because they were in the business of sending appointment reminders to patients. I'm sure many of you, next slide, Sharon. I'm sure many of you have, oh, I guess I'm mixed up on my slides. I'll just carry on. Many of you, have had the veterinarian call you or inform you that, your pet is, you have an appointment with your pet to have its shots, or your dentist is reminding you that you have an appointment. There's a viable business in Canada where a small number of firms provide the service of reminding patients that they have an appointment the next day with their doctor, reminding them, if you're not able to make it, cancel, don't forget to bring your pills, that kind of messaging going on at the same time that there's a reminder that you have this appointment. This is a viable business because the no-show rate goes down by half when patients are reminded about their appointments. So we approached this company, a small IT private company in Canada called ClinicConnects, and worked with them to develop the ability to send far more complicated messages, health promotion messages, and even messages that assist the practice to improve its clinical efficiency, its operations, like reminders of changes in hours, or changes because you're now offering virtual care, and you can send this information out to patients, and you can certainly reduce the number of calls to your reception and so on. So we worked with the company to make that capability possible, and also then to go forward and say to patients, as your family doctor, I'm participating in this program that is designed to help me better serve you and the rest of my patients. will you please complete this following questionnaire? Your responses will be de-identified and rendered private before I'm given feedback by the organization providing this service. So we have a website. It was on an earlier slide there that describes a lot of things in detail about the governance. Thank you, Sharon. The governance, how we've set it up as a not-for-profit with oversight, so that the data will never be sold to pharmaceutical companies, etc. And also all the privacy arrangements that we have in place to assure that no patient would ever be identified as an individual, and no provider would be identified. Sharon, let me turn it back to you. You, I think, are going to give more information about the ability of this service to send public health messages.
Yeah, so one of the partnerships we've developed is with the Eastern Ontario Public Health Unit. Some of you may know Paul Romiliotis, who's a pediatrician, and they run a media unit that has produced hundreds of health promotion messages and videos, all with public funds and available in the public interest. And so we've developed an agreement where those have been licensed to us, so that those could be sent, which would give, this is an example, I cut out of one of theirs, but allow links to videos, short messages, all prepared by their media unit to be tools for practices to send to their groups of patients. What we would add to this is at the end of each, any potential outreach message is a link to a short survey, as Bill said, with a proper consent sought at the first contact, giving people the option of opting out, informing them how the data would be used, and the link to the website continually with each contact so that they would know the purpose of the information collected. And essentially linking very short surveys like this example, no more than 5 to 9 questions, so something that can fit on 2 smartphone screens or a very quick email. So we're really keeping the burden down, but seeing if we can get high enough response rates as information is sent out to patients on their experience. During COVID, we would be collecting information on COVID-like symptoms, physical distancing, and relevant information that we feel could help decision-making. All of the answers are de-identified. Reports are shared back with the individual providers, but we can also aggregate them to get regional reports. And so that's, it's based on this function that we've developed a COVID-specific study that I'll just show you, which is that we would like to test by deploying CPIN in one family practice in 10 neighborhoods across Ottawa and Eastern Ontario, to let physicians share health information with their patients by email or text message with 200 patients in each neighborhood each day with the linked survey, to see if we can detect increases in patient-reported COVID-like symptoms. These are symptoms that do not require medical attention, that currently we're not recommending formal testing to confirm COVID with. It is just the presence of cough, sore throat. But if you're not a healthcare provider or otherwise at risk, these are not symptoms that are being brought to the medical establishment right now. To see if we can determine patterns of COVID-like symptoms and patterns of physical contact frequency by neighborhood, age, or other patient factors, which we hope will allow us to predict COVID-19 spread and resurgence better than existing public health testing programs, and seeing if we can model at which point does an increase in symptoms lead to confirmed or increased COVID positive to sort of give us an early warning system for COVID resurgence at the neighborhood level, which might allow fine tuning of our social or physical distancing policies, and also help us understand, based on age and other risk factors, the individual risk for our patient population.
Sharon,
Is that?
sorry to interrupt.
Yep.
In terms of, there's a number of questions and comments that are being made now. Would you like to address some of these now, both you and Bill, or do we want to hold them to the end?
Let's go now. Much better to be interactive.
Sure. Okay. So the first question is actually from Isabel, and she's asking, will this questionnaire be sent via the patient's chart, or will it be emailed?
So this system works in parallel, but outside of the patient's chart. The software links to the patient's chart to get the contact information, appropriate demographics, to make sure that targeted outreach messages are, that person falls within the category of selected targeted outreach messages, whether it's everybody over age 18, women over age 50, etc. And then it is sent via email or text message, but it is not sent via the chart. So it is not like a portal, and it does not imprint anything into the patient's chart. There are strengths and weaknesses to that. The strength is that there's no burden on the providers to address information coming into the chart. The weaknesses are that if a patient wants to respond, they can't send a message directly to their provider or to their chart right there. But we just can't have the level of surveillance for high quality data allowing a patient responses into the chart. It would just overwhelm practices.
Okay, thank you. Isabel, did that answer your question?
Yes, thumbs up. Thank you so much. My question was email in the chart or mailed like regular mail for people who don't have internet. And I think there's another question about that.
So that's a very good point. If we look at internet rates, our concern would be the lowest income or our oldest patients. We find, I think it's now almost 80% of the Canadian population over age 75 is on the internet at least weekly. Cell phone, I don't have the latest statistics, but mobile phone penetration, even among our lowest income, is very high. We know there are issues with data plans, but we know that it is being studied as a better way to reach patients, particularly of lower income. The rationale for choosing email over traditional phones or mail is it comes down to cost. Also, response rates. We did a pilot of this where we sent by either, we let people select whether they wanted a follow-up short survey by phone or email, and we found that email response rates were 60% on average, the lowest being the lowest income group with about a 45% response rate, and the highest being, going up, response rates going up by income group. High response to email across all age groups, and phone being the lowest response rate across all income and all age groups. So that it just was not cost effective to do phone, and it would be even less cost effective to do regular postal mail.
If I could jump in and add to that, the greatest challenge is not age, because older people seem to be on email, at least when they're being asked to complete a survey like this. The greater challenge is low-income people being underrepresented in the survey responses. That's clearly a weakness of our approach. One could maybe try to mitigate that by oversampling. the people that you are having most difficulty to meet?
There will be data available on who is answering and who is being sent the information. So we will be aware of the people who are not included, the people who are not getting it. Practices would know this income group is underrepresented, and it would require other solutions to do outreach. And that's where a smaller group might be eligible for a mailed outreach information campaign. But the benefit being you are now targeting a much smaller group than having to do mail outs to 1,000 people.
Thank you. Barb, you had a similar question. Has that question been addressed? Okay. If you unmute yourself, Barb, you could say.
Oh,
otherwise,
sorry, I did say yes in the chat box, but
Oh, you
yeah,
did. Okay,
Yes.
sorry. I
its impact from COVID are maybe less likely to have an email or use it regularly. But yeah, obviously you do the best you can.
So it's Bill again. If I can maybe give some context to this. We are hoping that we will be up and running such that this information is aggregated across the practices and reported to the decision makers in the public health authorities who are deciding about the physical distancing restrictions. So I think we can probably all agree that there are certain neighborhoods in Ottawa where the virus is more likely to have a second wave and have a kind of recurrence. And those are probably the neighborhoods in which people are the poorest and are more likely to be living in large numbers in small units, maybe in apartment buildings, and so on. So we think that providing prevalence data about COVID-like symptoms and breaking those reports down so that we describe how elderly these people are and what kind of work they're doing and what their circumstances are would enable the lifting of the restrictions to be done perhaps at a more granular level than is happening at the moment.
We also think that from a primary care perspective, understanding at the neighborhood level presence of symptoms, but also physical distancing behavior will help us better advise, reinforce messages about physical distancing for neighborhoods or age groups where that may be on the decline, and also better advise patients in terms of their own choices to return to more normal patterns, social behavior patterns.
Okay, thank you.
So our proposal, we are sending out submissions to granting competitions. We've actually been shortlisted on 2, and if we are funded, we think that by mid-August we can have determined whether or not this is feasible and whether or not it actually provides useful information that leads to better decision making. So we're going to do it in a relatively small number of practices, but sufficient for us to be able to do the mathematics and figure out whether we are in fact picking up a signal earlier than the usual testing methods that are in place now. And if that is the case, then other areas could very rapidly install this thing. As soon as you have the proper consent signed by the family physician and nurse practitioners, this can be up and running within 24 hours. So in a practice. So other jurisdictions in the province and so on would be able to jump on board. It'll be a bit late. It certainly won't give any information for the current wave, initial situation we find ourselves in, but we think this is going to go on for quite a long time until perhaps there's a vaccine available, so that we would then still be able to provide useful information to those areas that want to use it.
And we envision this, if it works, as a guidance now and better prepared next time. That such a service could be used for flu season, for the next pandemic. That what we're trying to build is a self-sustaining service where health promotion messages, patient education material can be shared, can be sent out. Data from primary care practices can be collected rapidly, and that if this is in place as a self-sustained system, it would be there next time as well for us to detect changes like the next pandemic.
Great. Thank you. Heidi's actually asked has a question just about Heidi, and I'm assuming this is asking for the CPIN website, and certainly we can put that on the chat so that everybody can see the address for the for CPIN. Is that right? Is that what you were asking, Heidi? Okay. Next, Laura has asked, I guess, a similar question to Barb earlier. Laura, has your question been answered? She wanted to know about whether there's risk not being able to contact people who are greatest at risk, elderly, no technology, phone, etc.
Yep.
Do you have a further comment?
No, all good, thanks.
Okay. David has asked a question about former symptoms to screen for likely. Will you ask questions about former symptoms to screen for likely? Actually, why don't you state your question there, David?
No, I think I understand that this is about current incidents and not overall historical prevalence. That all makes sense. I also wanted to point out this would be great for a competition that's currently being crafted between the CMA and the College Foundation to the tune of $5 million. The RFP will be out on May 4th, and the turnaround for projects will be sort of 6 months projects. So it would really be perfect if you'll probably secure funding by then, but if not, it would be perfect for the next wave.
Excellent. Thank you, David. Next question, again from Heidi. Has the platform built-in artificial intelligence, so the individual survey responses don't need a person to review, but could flag high, medium, low risk, so data are triaged?
So among the many things that COVID disrupted, we had a CIHR meetings and planning grant to build a team to look at the application of artificial intelligence methods to CPIN data. And we have a really impressive group. Artificial intelligence is not what I do, but I recognize its power. And we think that there are two really crucial opportunities. One is at the fine-tuning the patient interaction level based on their demographics, targeting the message appropriately based on the first answer to a survey question, going down algorithms as to what would be the better symptoms. So David asked, current symptoms or past. We could ask, have you in the past, and then take them down are we likely dealing with somebody who has immunity type survey, or you have current symptoms, is this likely COVID now type survey, so that we could use that sort of data there where artificial intelligence methods could do that. The machine learning approach could also help better target outreach messages where based on a small amount of patient demographics, age, postal code, for instance, and the fact that every outreach message is, the first question we asked is how valuable. They're predicting that certain messages would be more valuable to people like you. So we would recommend that these messages go to this groups of patients. So definitely ways of using it. We have not built that in yet because we're at the start, but we're working and probably in the next year going to put in a grant with people who will develop that functionality. We think that's a huge potential, and I think it's, Bill, you can speak to it, but one of Bill's passions was to use this to have patients give us in primary care information like what community resources do you use, and then use targeted questions to get a little bit more information on that, and start to develop community profiles of resources that promote people's health based on our patient's perspective. So a doc like me who cares for people in a 2-hour radius could quickly get community profiles of resources from patients in that community from the 10 practices that serve patients in that region without me having to be an expert in Pembroke, in Stittsville, and Orleans. And again, that it would be where machine learning methods would be applied to find patterns in the data that we're collecting from our patients. And then the tremendous potential to find patterns based on experience that we don't pick up at our practice level, but looking at a similar experiences shared across socioeconomic groups, age groups, postal codes, would help us better understand what's going on with our practice population by sharing across our practices.
Great, thank you. I see we're at about the midway point. I suggest that maybe we take one more question for now. Carry through with the presentation, Sharon, and then we'll have time for more questions. So the next question is actually from Gary, and he has asked if there's been any negotiation with TOH and its fits to utilize my chart, which has similar functions, and is there any way that he can help facilitate this?
We have not started yet, and I think that would be very powerful. My chart has similar functions, and I believe it can do sort of a one-way communication survey without imprinting back into the chart. But I welcome the opportunity to talk with him and see how we could make this compatible.
Great. Okay. All right. So why don't we continue with the presentation, and then we'll continue with the questions and discussion.
So that, Doug, is, I think, handing over to you to talk about some of the other, what we just presented was an adaptation of a system we've been working on for 5 years. We were talking 3 years ago, we were talking about how important this would be to have when there was a pandemic. And then suddenly it was upon us, and we've been moving faster than certainly the IT company we've been working with ever thought we could. But there are many other studies. As I said, we have 3 funded studies currently to use CPIN. That this one CPIN LEAP is started, and 2 were to start in the next 6 months. So this, I think, is when, Doug, you could talk a little bit about using CPIN for medical education.
Yeah, for sure. Thanks, Sharon. So this is a project that's really just about to get underway. And certainly if there are any clinics that are interested in joining by signing up, you'd be most welcome to just get in touch with either myself, Sharon, or Bill. And essentially, this is about utilizing CPIN for trainees. And the idea here is to take one of the one of the surveys that has been developed through a prior study. This is Sharon's involvement with the CIHR transformation study. One of the surveys being patient-centered communication. And the idea here is that residents and preceptors can send, after seeing a patient, so this would be post-visitation, would send out one of the short survey, which would only be 5 questions actually, to a patient, and getting response on the communication. You know, these are questions around, you know, was I heard, was I involved in the decision making, etc. And the idea here is that residents and preceptors who partake in this, after a 3-month period, a report would be generated, and this report would have anonymous responses from all the patients that an individual resident has seen, and they would be able to also see all the other residents who are partaking in the project. Again, this would be de-identified, but they would see how their responses were, they'd be able to compare their responses. The idea here is that these responses, this report, could be shared with the preceptor during a structured progress review in conjunction with the other assessments that that a resident receives over the course of their training. And then based on this feedback, you know, there may be an opportunity to try new approaches. And then the whole process would continue for another 3 months. So the whole purpose here is to improve patient-centered communication. So as I said, the study is just about to be underway. We've received ethics review to do it. And we currently have a few clinics that are willing to participate in this. A benefit, of course, is that you do, by partaking in the research, you actually, for the period of the research, you do have CPIN at your disposal. So that's just a little bit about the CPIN LEAP study.
And before going to general discussion, when we started, we said, just like in clinical care, we've been adapting on the fly at really unprecedented rates, but one of the, there'll be a lot of good that comes out of this in terms of forcing us all to adapt quickly, but some of the new collaborations that we've developed, like partnering with the Eastern Ontario Public Health Unit and finding this wealth of tremendous patient education material that could be brought to practices without them having to go and find all of their own information. We've also just begun a collaboration with the Communications Lab with some colleagues who are actually on the call now from U of O, where we hope to benefit from their expertise to develop better messages, more targeted messages for specific patient groups, physical distancing messages, should we get to a point where primary care providers are trying to reinforce public health messages. How do we craft that age of, you know, is there an age appropriate message? Does neighborhood data matter? Does, you know, to be able to learn how to better communicate with patients using a tool like this, we're bringing in some communications experts, which we're excited about. So these are some of the collaborations that we're developing, and we hope will only make this a better service, as you said, for the long run.
Thanks, Sharon. Okay, so again, let's we'll go down the list of questions around this study, and then I'd like to open it up to the floor for people to ask questions about other questions that they may have around the COVID crisis, and research questions that we should be pursuing. So, Barb, I see that you had a next question here around demographics. And I think Sharon may have addressed that, but you may have a further comment.
No, I think Sharon addressed it when she was speaking, and Bill too.
Okay. All right, thank you. Claire, you had a point around funding next.
Yeah, hi. Really nice presentation. Very impressive what you put together. I know there was a lot of hard work to get it to this point. Two suggestions in terms of funding. One is more immediate. There is Tahamo Innovation Funding. This followed up on Gary's sort of offer. If you have a Tahamo doctor, you know, this is a quick put your idea in. So I just would encourage you maybe to think about that. And then with the consumer aspect that you have on it, Canada Health Infoway really has a strong focus on consumer focused you know, tools. And I just wondered if you haven't connected with them, I would be happy to sort of make the introduction in terms of, again, another larger funding opportunity for this.
We got a CIHR.
Maybe
Go ahead, Bill. You go.
I was just going to reply to thank you, Claire, for your suggestions and your offer. The Canada Health Infoway actually has just funded us for a scale and spread initiative, but it was done through the CIHR, so we haven't really had a direct, much directly to do with Canada Health Infoway, and it is something that we would like to pursue.
All right, so I'll do a follow-up, like an e-introduction for you.
Thanks, that would be great.
Great, fabulous, thank you. Barry, you had a question about surveys and retirement homes. You want to speak to this?
I'll try to answer that one. It's Bill. So I see, Barry, that you don't have any gigs for your band, and you're not singing, so that you're maybe you have opportunity to pursue this. No, seriously, the company that we're partnering with is called Clinic Connects, and they have seen an opportunity to take much of what we've helped them develop and apply it to the long-term care sector. And they're actually going crazy right now with they're almost overwhelmed with the number of long-term care homes that are asking to use this communication system so that the homes can communicate to the family members and relatives of the patients inside the homes. So that is happening. It's exploding for them in terms of how busy it's making them. But neither Sharon or I or other members of our team are part of that work. We are focusing our work on the communications, using this platform to communicate and collect data within family practice. But it would be pretty simple to put you in touch with them or anyone else on the call who has a particular interest in the disaster that's happening in the long-term care sector. And I'm sure they would be very appreciative of having some, real doctors to talk to about how to, craft their messaging and so on.
Great.
Thanks,
Bill. Oh, sorry, go ahead, Barry.
I just talked to that. It wasn't quite that, Bill. I'm thinking that inevitably we are going to be surveying retirement homes, and I'm not sure about long-term care homes, but theoretically anyway, many retirement home residents have spouses, and they also have family doctors. So we would be able to identify responses coming by address. Retirement homes have a single address, and I'm thinking sorry, I didn't think about this before just now, but I'm thinking there would be potential for identifying an outbreak in a retirement home, at least just doing what we're doing. Finished.
I'm not sure. I haven't quite figured out. I don't understand how that would happen, Barry. What you mean? The relatives of people that we're dealing with in their homes would sort of be like the canary in the coal mine for the long-term care facilities?
No, I'm just, let's forget about long-term care for now. I'm thinking about retirement homes, which are also under siege right now with COVID. Some retirement home patients are actually quite bright, and they would be on the internet. Some retirement home residents have, they may have cognitive problems, but they have spouses who are living with them who would be able to respond to a survey. So these surveys will be going out to retirement homes. There's no doubt about that, just because they are still attached to these, the patients are still attached to these family practices that are going to be included in the studies. So I'm just pointing out an additional valuable outcome, I think, that would arise. Are you still puzzled?
I hear you. We hadn't thought about it from this perspective. Thank you.
Okay.
Okay, thank you, Barry. Next question comes from Lise, and this is a question for you, Bill. What is your timeline to have this operational and reporting to public health?
Middle of August, Lise. Well, sorry. We can, by the middle of August, we will have answered the research question, which is whether or not we can pick up a resurgence, a new kind of cluster of cases faster than the existing testing approach. So here's what we're thinking in terms of timeline. Hopefully we get an announcement that we're funded within a matter of weeks. Very quickly, we can get this through ethics. We've done it before for Doug's SEEP-IN LEAP study, for example. And we can implement this really quite quickly. We would choose to implement it in practices that already have patient emails or telephone numbers for their mobile phones in their electronic medical record. And we can get it up and going quite quickly, actually. But then we have to run it for quite a stretch. We think that all this will be happening after the current wave of the pandemic has happened. It won't be extinguished. There'll still be susceptible people in the population, and there'll still be little places where the virus is still present. And we envision a kind of whack-a-mole kind of environment where we think we've got it down to just a few places in the community, but then suddenly there's another bit of an outbreak that starts in Bruyère, or another bit of an outbreak that starts somewhere else. And our hope is that we will be able to show that we can detect those subsequent waves or recurrences within some weeks of collecting this data on a daily basis, and that we'll have an answer about whether or not this in fact works by the middle of August.
One of our
Sharon, have I explained that properly?
Yeah, one of our challenges is during our previous leisure life, we envisioned sort of a 6-month run-in period where we teach a practice how to use this, and over 6 months we expected sort of an updating and developing clinical processes for updating emails, mobile phone numbers, and informing patients. So doing this on a more rapid timeline, we're not sure. We'll aim for practices that have more email contacts and more are more comfortable using that with patients. But down the road, I think that's something that we would have to help practices develop the processes to get emails, text messages, updating them. It may be something that can be done more easily when there's a lot of virtual care going on, because phone contacts can then be used to explain there are other ways of reaching us. Can we update your contacts? Or it may be that it really slows things down. We'll have to see.
And I would say to Lise, the biggest threat here, well, first we've got to get funded, but assuming we're funded, the biggest threat in my mind is that when we seek to recruit practices to do this, they're just going to sigh and say, look, this is a great idea, but I am simply too busy and overwhelmed, and I cannot do anything more. And, you know, we have worked hard to reduce the burden to the practitioner, but it's not zero. It takes, you know, like an hour and a half to onboard this, an hour and a half of a provider's time to, you know, direct, give us the rules we need for who gets what kind of messages and so on. My biggest concern is that we will find that it's not feasible because practices will simply say, I can't do it. So, you know, in our grants, we're seeking money to pay doctors for their disruption. And we would provide the service for free. Normally, it would cost $50 a month to have this service, to sort of cover off all the costs and so on. And out of our grant budget, we would pay for that for free. And then, of course, the practices might be able to actually save themselves a bit of time by sending messages out that, you know, inform patients about changes in their processes so that there are fewer calls to reception and various things like that. So we would work hard with the practices to reduce the burden, but we can't reduce it to nothing. And so I would put out a plea, if there are primary care people working in primary care practices on the call that are interested and that think that they might like to participate in this, to please let us know. We could get started. We don't actually have to wait for our grants to be funded, to put this into a couple of practices and start going with it almost immediately.
Thanks, Bill. Another question here. This one comes from Lois, actually. And the question is around patient partners in the design of the CPIN system and the surveys and so on. And wondering if we can answer that, or if Lois, you have any comment on this.
We have the long-term governance model for the CPIN system actually envisions having a patient advisory group who could advise on the topics, on the meaning of the feedback that we're getting from patients, on the sort of the oversight. So that is part of our long-term governance plan. We have funding to we have involved patient groups in a study that Doug led, looking at developing the optimal measures that you would send via CPIN to assess cardiovascular preventive care. And very, very interesting and very important because let's just say taking blood pressure is not the first question they recommend we ask to measure our performance. But that is something that we'll put on hold until there's sort of a more normal ability to get face-to-face interactions. But two of our funded projects envision patient advisory groups looking at helping us develop the content for outreach, as well as the appropriate measures to evaluate performance for specific goals.
I may jump in, Lois, it's Bill. There's a lot of ways you can think of this CPIN service. And one of them is as a patient engagement platform. It provides, you know, we've really focused on COVID here today, but we've been working on developing this infrastructure that we now think will be very useful during the COVID epidemic. But we started on this years ago, and it essentially is a data collection infrastructure to permit family doctors, primary care practices to do quality improvement. It allows them to collect data from their patients, understand some aspect of their work, and then focus in on something where they feel they can improve their performance, introduce a plan, and monitor their plan over time by going back to the patients and surveying them and asking if in fact that aspect of the work is improving. So this gives patients input into the way that family doctors are working, and it makes them partners in an effort to improve the way services are provided. So, and that's, you know, it is important to have patient representatives on our project advisory committees, no question. But, you know, we can only have 2 or 3 members of the public working with us on our implementation systems. But this allows us to engage thousands of patients.
Lois, do you have any comment?
No, I think that's great, and it's really good to hear that there is going to be a role. I think from the work that we've been doing, I would just encourage you to think about engaging them with even the design of the surveys and how they're going out. I think they're a really rich resource. So it's good to hear that you've got some of that on your radar. That's great. Thank you.
Thanks, Lois. Next question is from Isabel. In your grant request, think about a budget not only for MD replacement time, but is there a role for RNs to be involved? And this is a great opportunity to include registered nurses in research.
Yes.
I'd just say, I mean, we've, some of our slides have used exclusively family physician, and part of it is in our rapid response, we've been responding to both private industries who don't take proposals, they take a pitch deck, to physician-centered competitions. But just last week, Bill and I were presenting to a colleague who I've done research with, really focusing on the performance of interprofessional teams, and a study that we've been trying to get funded for 4 or 5 years to look at the work that is done by different members of interprofessional teams for different populations and the patient experience of working with different members of the team. And it's been very hard to figure out how to collect that kind of data. So we were actually just talking about using this system, She's Occupational Therapy. After a visit with the occupational therapist, if the team agrees this is a priority, could a certain, you know, short survey be sent to focus on what are the outcomes or the patient experience that is happening after a visit with the nurse or the dietitian or the occupational therapist, for interprofessional teams to get a better understanding of who they're helping and who is playing what role. So very clearly that's on our radar, and we think a very powerful potential. The first is to get it up and running, make sure it's acceptable to practices and patients, and then start fine-tuning its roles at the practice level with each team.
I would like to thank Isabel for this, making this point, and apologize for having been so physician-centered. As Sharon said, it's because, you know, one of the grants that we're writing at the moment is to the PSI Foundation, and they're funding physicians. So we are kind of stressing that aspect of it. But in fact, one of the great strengths of this CPIN system is any provider in a primary care office with whom the patient has an appointment can be, we can follow up with a survey after that appointment. And even the survey questions can say, regardless of who was seen, they can be about, did any member of the team speak to you about whatever? So it's a strength of our approach that it's not just physician-centered. That said, there is one issue that we can't do anything about. The databases at ICES are very physician-centric. And it is part of our plan as we seek consent from the patients when they are, just before they fill in their surveys, to inform them that we will be linking the survey results to the administrative databases at ICES. That, of course, gives us tremendous power in terms of linking to all sorts of information about, you know, previous and other utilization patterns and so on for these patients. So, but those databases are linked, well, are dominated by physician data.
Can I add something? So I work at Bruyère with a lot of the team members we see on the screen. And I've had every physician password for ICES for many years, and I'm the one who does all the research in the chart for different chronic disease. So that was a way that I was able to do a lot of the research to find the patients that were vulnerable. And the other thing I want to say is, as a chronic disease RN, and I see my own population of patients, we do use a survey for assessing chronic disease. So that is familiar, and it's things that these kind of roles are great for RNs who are involved in academic clinics or as well as primary care clinics. It's just, I just thought you don't need to apologize, Dr. Hogg, for not thinking of RNs. It's because if the contract is already done and the replacement has been agreed that the compensation would be for physicians only, it's hard to get around that to get replacement for RNs. But the other thing as well, in our clinic, there's unions for RNs. So it would go with seniority. They would have to kind of, you know, post a position if the RN gets to help with the project. It's a little bit tricky with union for the RNs.
There are other tricky aspects to it as well, just involving the hospital. So it'll probably be a slower deployment there.
Thank you, Isabel. I'd like to actually just take one more question, and then we'll reuse the remaining time if anybody has any particular point that they want to bring up around COVID or any questions that they're actively pursuing. So last question I see here is from Claire, and I see Simone is also in the discussion, is on as well. And just how is this linked to the open network? And I guess, is there any possibility for this to be connected?
We certainly think so. Again, this is designed first and foremost to be a practice tool for primary care practices to help them connect with their patients, communicate more efficiently, and do quality improvement where they can incorporate patient experience. That's the first and the foremost goal. We've scrambled and adapted to make this something that can respond and help primary care and public health in a pandemic. But I think this is something we've had some informal discussions over the last few years that we see this as, and you know, we're talking with the College of Family Physicians of Canada and the Association des Médecins Francophones du Canada. to really help this be integrated into continuing professional development and quality improvement. So at the stage where that's something that you want to discuss, we think that this would be a good fit. It's meant to be a quality improvement tool.
Great.
Maybe I can build on this. So maybe these two approaches, although they haven't been linked yet, come from sort of different directions at the same problem. And so because Open, along with all the PBRNs in Ontario, have submitted a grant application to do, with an objective to do something similar to what you're doing, and that is to track the potential resurgence or the fluctuation in the in potential cases of COVID as well as confirmed cases of COVID, track the type of symptoms that are seen so we're better informed. And this would be based on existing EMR data and extracted frequently to, for actual proper monitoring, because right now SIPSN does not extract regularly. So I'm thinking that the type of data that that you are collecting are maybe trying to get at the same thing, but using a different method. I don't know, have you guys thought about how the two systems could be integrated?
We've put in a couple applications to collaborate with SIPSN on other questions using CPIN. Using CPIN for COVID resurgence, one of the things we're trying to get at are the symptoms before they come to the medical system. So many of these symptoms, people appropriately should stay home and not come into their clinic. And right now they certainly can't come into their clinic, and we don't know how long this is going to go on. So it's getting the even lower level symptoms to see if that predicts resurgence. As for collaborating, again, my sense is it's as easy as just working together and sharing our data, which I think would be very valuable. I don't think it's capturing the same data, the symptoms before they reach the medical system, the symptoms that have reached primary care, and then the symptoms that warrant public health testing or hospitalization is sort of a hierarchy. And I think that there would be tremendous value to understanding the relationship between them.
Yeah, I agree. Also, Simon, our approach, we're working with a statistician, Richard Webster from the CHIO Research Institute, and he's proposing that we use a time series analysis to answer our research question about whether or not we can detect these new clusters more readily than current testing approaches. And I don't know much about time series analyses. I just wonder whether you've used that kind of approach before, and whether that's in general the approach that you're thinking about through these SIPSN related PBRNs.
Yeah, so I in both cases, yours and for the CPIN and for Open, we're collecting data. What we do with the data then is up to how we analyze it, depends on what we're trying to achieve. So you're right in that, like a longitudinal analysis is more sensitive at picking up differences. So we have not actually proposed analyses. We've proposed to collect data that would allow us to then do all types of analysis. But I agree with you, Bill, that the longitudinal essentially is more sensitive at picking up differences. Yeah, so I agree with you that these are not duplicate. In an ideal world, the two systems, so the Open PBRN system, one that extract regularly, collected data that's collected regularly during encounters, telephone, in person, and all that is useful, as well as data collected from patients. They're complementary. And as in, other applications, other usage you might want to have for them, they'll bring different types of information, but can lead to the same general objective. So, if some symptoms are occurring that have not been reported to the provider are recorded as in CSPN, then we can potentially pick up something earlier. Whereas the EMR data has the value of having the provider input on there as well. So I think they're complementary.
And be clear that this CPIN is designed as a quality improvement tool to bring in what was missing, patient experience data to quality improvement, where we really don't have that. Patient experience data for quality improvement is just one slice, one sliver of the information that is needed. And it very much needs to accompany eventually EMR data, administrative data. And so the long-term future would be combining these into an effective, usable dashboard type thing for providers. We're just addressing the patient experience component and trying to develop the infrastructure, because that doesn't exist in primary care, whereas the hospitals have it. We don't.
I agree with you, Sharon. Yeah, I see it the same way.
Yeah, I agree too that the approaches are complementary and would, of course, want to collaborate with you, Simon. I just make an observation is that in a perfect world for this particular COVID-related study that we're proposing, we would like to be able to select practices rather than go to an existing group of practices that are already embraced and engaged in an existing practice-based research network. We felt that we wanted to very carefully make sure that we selected practices so that we sort of covered the postal codes of the city or Eastern Ontario. So, it may be so difficult for us to recruit practices at this moment in time that we don't actually have that luxury. We just don't know. On the other hand, we may find that people are extremely willing to work with us and participate in this study because they can see the value that it brings and the importance, and just recognize in a general way that good research is going to help us get the knowledge we need to respond in the best possible way to this horrendous menace that we're threatened by. So maybe it'll be easier for us to recruit than usual. We just don't know.
And Simon, I'd say that when funded, we should talk about how to combine the data, because I think it would be really interesting to look at that hierarchy, that progression of symptoms, community level, practice level, public health testing, and what are the trends that we see. So maybe we'll let you know if we're funded, when, and we could work on trying to develop that.
Yeah, absolutely.
Yeah, I say to Simon, good luck. I hope you get funded. Just don't take it all. Leave a little bit for us.
Yeah, I mean, the applications are really quite different. I hope that, that many of us get funded. It was really disappointing. In Toronto, they had an internal competition with I think they had $8 million to give away. And they had 325 applicants or something. They ended up funding, I don't know, maybe 30 or 40. And none of the names are recognized. So, except for
it's a brutally competitive world we live in terms of getting research funding, that's for sure. But maybe, there's almost every other day, there's a new competition announced. And we have been shortlisted now twice. So we may find out tomorrow that we've been funded.
Oh, wow. Wow. Okay.
Well, on that note, everybody, I can see by the time on the wall, we are out of time. This has been an extremely fruitful conversation. I thank you all for your participation. I had hoped to have time to actually discuss other research questions and opportunities that you may be pursuing yourselves as related to response to COVID. I still want us to have that opportunity. If I can suggest, if you send me an email, if you're interested, we can actually have another forum just like we have right now in the form of grand rounds, but it may be just you know, a conversation, a point of sharing, of asking questions, getting suggestions. So please send me an email if you're interested in that, and we can certainly try and arrange another forum for discussing COVID questions and initiatives.